Hi, this is Minnis Joannides, Chief Medical Director at Optimum Re, and this is the Optimum Academy, the Oncology 101 series, video number 2, Introduction to Cancer. So when we talk about tumors, we want to know if they're benign or malignant lesions. So precancerous lesions are not true cancers, but have a tendency to develop into them. So a good example would be like a colon polyp or a mole that looks suspicious. It might be precancerous. And carcinoma in situ is a lesion that has all the characteristics of malignancy except invasion. It has not yet spread past the superficial epithelial layer of origin. So you can see in the picture below, to the left are normal cells, and to the right are low-grade dysplasia or precancerous cells that look different. They look darker, they have larger nuclei, and so that's the difference between normal cells and something that looks more worrisome. So when we talk about tumors, we talk about the extent of tumor involvement in tissues, and the two ways we traditionally look at tumors are the grading of the cells, what grade are the cells, and what is the stage of the tumor? How large is it? Has it spread to more than one portion of the organ involved, or has it spread beyond the organ involved into other neighboring or distant tissues? So grading and staging are key, and that's what we look at when we get a pathology report. So this is a good way to think about sending a medical referral or referral to one of your compatriots that you're working with in the underwriting department. So when you want to ask about a particular case where the case has involved cancer in the past, you want to know the age of the applicant. So here we're going to use a 62-year-old male with X kind of cancer diagnosed in what year. We want to know about the pathology report is on page X and shows the grade is X and the stage is X with any explanation that may be helpful. And then the applicant had what kind of treatment? Did they have surgery, chemo, radiation? And if so, if they had chemo and radiation, maybe they're at risk for secondary problems like a secondary cancer from the chemo or radiation, or secondary risks from some type of adverse thing that could happen from the chemo or radiation. So, is there any downside risk from the treatment that was used, let alone risk from recurrence of the cancer itself? And then the applicant hopefully returns for annual or more frequent follow-ups, which have been negative as recently as whatever the date of the most recent visit was that showed that the person is still doing well. So when you package the referral like this, it's helpful. It gives the information that the decision maker would need on how to advise on where to go rating-wise in this particular case. So when we look at tumors in terms of grading, that refers to a description of the tumor tissue's microscopic appearance as described on the pathology report. And it could be graded or scaled from 1 to 4, or 1 to 4 using Roman numerals, or low to high grade, or in the case of prostate cancer, we use Gleason score. So a 3 plus 3 equals 6, that kind of thing. The lower the grade, the more closely the tumor cells resemble normal tissue, and the less likely they are to be harmfully malignant. The more bizarre the cells appear, the higher the grade and the more concern for a worse malignancy that has the potential to spread to other areas. So below, I put what a typical breast cancer grading system uses, and it's abbreviated SBR for Scarf Bloom Richardson, also called Nottingham, grading for breast cancer, and it goes from a low grade to a high grade. And you can see in the pictures below, there's grade 1, grade 2, grade 3. Grade 3 is the highest grade, the more worrisome cells. And with breast cancer, we use a point scale to grade the grade of the tumor, and we grade in terms of points for how many tubules there are. The more tubules, the better, and tubules are pointed out with an arrow in the slide to the left. Then we also look at the nuclear status of the cells. How do they look? Are they normal looking or abnormal looking? And then we also look at the number of mitoses that are present. The more mitoses, the worse the prognosis. So this just kind of gives you an idea of how we grade tumors. This one happens to be breast. The other important factor is the stage. So in staging tumors, we use the TNM format for tumor size. T is for tumor size and location in different lobes. N is for nodal spread, an evaluation of the extent of the tumor spread from its primary site into lymph nodes. And M is widespread metastatic invasion by the tumor to more distant sites. You can see here we often convert the TNM staging format into a stage that's numerically 1, 2, or 3. So you can see that stage 1 would be the more limited cancer, and the stage 3 would be more extensive and more worrisome, and either a higher rating or declination of the case. So using the TNM staging of tumors, that method, the T refers to the size of the primary tumor. TIS is carcinoma in situ, and then T1 through T4 shows progressively larger tumors. N refers to the presence of localized lymph node involvement. NO means, or N0 means no lymph node involvement. N1 through 4 is progressively more lymph node involvement. And then M refers to metastasis. M0 means no evidence of distant metastasis, and M1 through M4 shows an increasing degree of metastatic spread. Now here is estimated cancer incidence versus cancer deaths, and this is in the year 2017 in the US, and these are estimated, but kind of gives you an idea of the worrisome nature of certain cancers. So in red, I've circled the estimated new cases and the estimated deaths. And you can see for colon cancer, about 98,000 colon cancers are expected, about equally divided between men and women. And the estimated deaths from colon cancer is about half of the cases, more or less. However, in the second line I highlighted, pancreas, you can note that there is a much higher incidence of death or estimated death in the new cancer cases. And that's the problem with pancreatic cancer, is that it's in an organ which is located deep in the abdomen in the retroperitoneal space. It's less likely to have symptoms. You know, in colon cancer, you may have bleeding that's noted, whereas in pancreas, you know, you get these non-specific symptoms that are, so the cancer is diagnosed at a much later, more dangerous stage. So the risk in pancreatic cancer is higher. Lung cancer has a very high mortality, and in the 220 plus thousand cases estimated, 155,000 deaths are expected, which is very high. So now we have a good kind of idea that pancreatic and lung cancer have a very high mortality rate when those are diagnosed. Whereas if you look at the bottom two red lines across in breast and prostate, despite the large number of expected new cases, the death rate is much lower, and that's because, you know, we're able to adequately and successfully treat breast cancer and prostate cancer in many cases to limit the mortality risk. So the highest risk cancers are lung and pancreas, as we just noted. Well, let's take a look at, you know, regarding breast cancer. When a woman who's 38 went for a mammogram, she had what was described as a nodule. The radiologist says it's possibly benign. And so an ultrasound was done, and the nodule is solid. It's not cystic. So it's not a breast cyst. So the radiologist suggested a repeat study in 6 months from the time of application. But, the woman decided, maybe I should get a life insurance policy just in case. So what should underwriting do here? Well, this is difficult because we can't really see the nodule ourselves. We're relying on the radiologist's description, and the radiologist said it was possibly benign, but we don't know. So, what to do. So I'll just give you some ideas that I use. There are no normal breast nodules, so breasts don't normally have nodules in them. The radiologist does not have X-ray vision to tell the cell type that's in that nodule. So, unless you are pretty certain that this has been stable for quite some time and that it's not cancer, it might be a concern when you're underwriting a large case or any case. And, it certainly helps to have a biopsy or the nodule removed and have a path report. And when I used to do structured settlements, which you may know what those are, it wasn't unusual to see a case where a woman such as this one had a mammogram done, had a nodule noted, and was asked to return in 6 months for a repeat. And when they returned in 6 months, they had widespread breast cancer. So, it underscores the fact that no one knows exactly what's in that nodule until you remove it or biopsy it. So that may be the best course of action in cases like that. So, can cancer survivors get life insurance? So applicants for life insurance that have survived cancer are often candidates for life insurance if the treatment has been successful and some time has elapsed since their recovery and return to good health. So possible rating and wait times from successful treatment are related to the specific type of cancer and the stage or degree of spread prior to treatment. And you need the path report. So that's a must in order to underwrite cancer. Cancers that have spread or metastasized to other areas of the body are not candidates for life insurance. So when we look at skin cancer, we see a lot of applicants who have had a basal cell cancer or a squamous cell cancer removed from their skin, and they often get very favorable ratings since there's very limited risk from basal cell or squamous cell cancers of the skin. If you have a squamous cell cancer in the lung, obviously different situation, but on the skin, a small squamous cell cancer can be removed. They may have just an excision or a Mohs surgery to remove those. And, the person goes on about their business with no mortality risk whatsoever. However, there are some familial syndromes where they have numerous, skin lesions that might be more worrisome. But the real risky skin cancer is melanoma, which I highlighted in red. And we look at the size and depth of the melanoma to determine its risk and is there any evidence of lymph node involvement, which would be very worrisome. So we get an attending physician statement on those kind of cases to make sure the melanoma has been adequately treated. When you see a melanoma, there may be an initial removal and then there may be a more wide excision of the area to make sure that all the melanoma was removed, and there may be some sentinel node that is removed as well to determine if the melanoma has migrated to a node that's nearby. So depending on the depth and extent of the melanoma, applicants may be rated. If the situation is much more worrisome, they may be declined. So that's really the skin cancer to pay attention to when underwriting a case. In breast cancer, ratings for life applicants with a history of breast cancer depends on what the size of the cancer was, the cell type and extension, as well as details of successful treatment, which may include surgery, chemotherapy, or radiation. And then the younger the applicant, the more concern there might be, or higher rating. And flat extra premiums, so extra dollars per thousand of face might be applied for candidates who apply for life insurance only waiting a few years after treatment. In lung cancer, as we said, it's one of the more worrisome cancers. So applicants for life insurance should apply only after they are long past their successful treatment and have done well. And of course, they no longer smoke tobacco products. In prostate cancer, with early detection, limited prostate cancer is curable with treatment, and healthy survivors can be considered for a life insurance policy. It depends on the stage of the cancer and the grade. And in prostate cancer, we use Gleason scoring. So typically a Gleason 3 + 3 = 6 is found. So after radical prostatectomy, the PSA level should be 0. After radiation, there may be a low level of PSA, which still may be acceptable. And we can often take survivors of prostate cancer for life insurance with or without some sort of rating. Other cancers that we note in applicants for life insurance are history of thyroid cancer, which usually has a fairly good prognosis, testicular cancer and limited colon cancer, as well as Hodgkin's disease, where there's many survivors that we can later consider. However, the worrisome types of cancer are pancreatic, gastric, esophageal, bone, brain cancer, myeloma, leukemia, and liver cancer. And often those candidates are declined because the mortality risk is so high. So here's a study from one particular life insurance company, and you can see that I've highlighted in green lung cancer, and these are the years after the policy was issued and when the deaths occurred in this particular mortality study. And if you look at the totals to the right, the largest number of deaths was for lung cancer at 358 for any particular type of cancer listed. And that's typical of life insurance companies, that lung cancer leads the pack. And one of the reasons is, in life insurance, if someone has stopped smoking for 1 or 2 years or whatever the case may be, we often consider them a non-smoker when they apply, so they get non-smoker rates. However, those people are still at risk for lung cancer for maybe 15 or 20 years after they stop smoking. So often life insurance companies have lung cancer deaths in so-called non-smokers. Those are people that used to smoke cigarettes, no longer do, but they're still at risk for lung cancer. And then you'll note the much smaller number of prostate cancer deaths highlighted in red here, where only a few deaths are noted each year, partly because surveillance of prostate cancer in men is easier to do with PSA testing, and the treatment is much more successful. So that completes our oncology series in the Optimum Academy. Thanks for attending.